The alar ligament runs from C2 to the occiput. In order to test the alar ligament, the patient is positioned in supine, the C2 spinous process is stabilized with a pinch grip. The head is side bent or rotated away from the side being tested. Any excessive motion or lack of a firm end feel is a positive test. To test the transverse ligament, the therapist supports the occiput while the two index fingers are placed in the space between the C2 spinous process and the occiput. The head and C1 are then moved anteriorly as a unit on C2, avoiding flexion or extension of the neck. The position is held for 10 seconds. Abnormal findings include abnormal pupil response or nystagmus, soft end feel, muscle spasm, dizziness, nausea, paresthesia of the lip, face, or limb, or lump sensation in the throat.
So when we're examining the cervical spine, there's different regions that could be causing the pain, so we need to isolate each region to find out where the issue is. If we're just going to check out the mid-cervical spine, all we're going to do is have our patient sit up nice and tall and turn their head to the left, bring their chin over their left shoulder, and turn their head to the right. And that's going to be mostly mid-cervical. If we want to isolate the upper cervical, we can either flex or extend. I like to flex. So we're going to bring your chin all the way down to your chest and then rotate your chin to the left and to the right. So again, that's upper cervical. And if we want to differentiate between the lower cervical and the thoracic, our patient's going to give himself a big hug, right? And we're going to rotate one way, and you're going to look over your other shoulder. Good. And then rotate the other way, and then look. Good. So in this position, if you rotate, go ahead and hug yourself again, to the right, and then you can turn your head to the left. If your range of motion gets better or the pain goes away, then we know that the issue is in the upper thoracic. If your range of motion gets worse or the pain gets worse, we know that it's coming from the lower cervical.
The downglide is the examination technique used to assess mobility within the cervical and upper thoracic spine. The therapist places his second MCP joint over the facet joint of the motion segment, translating from right to left in the orientation of the facet. The axis of rotation is through the patient's nose. As the therapist assesses lower segments of the spine, the patient's neck must be further flexed in order to adequately assess its motion. The therapist is in a squatting position, and the force of arms directs the force of motion. While performing this technique in the upper cervical spine, the motion is going to simulate the motion of a steering wheel of a small car. As you go further down the cervical spine, flexion of the neck increases, as well as the steering wheel. As you assess mobility with downglides, it is important to ask the patient if the movement produces pain. If you are performing downglides and the joint feels closed down, we will treat this with an upglide as it opens up the joint. When performing upglides, the therapist will follow the direction of the facet, grab onto the pillar, and pull up with a little bit of rotation. The therapist needs to follow the facet plane up through the eyes for a comfortable and effective treatment. For upper thoracic treatment, the therapist places one hand on the patient's shoulder.